And as a reminder, this series is made possible with funding from IDPH and the Community Health Assessment and Planning Grant. Today's session will be on some data sets from IDPH, and we'll be having experts share those data sets with you and give you an opportunity to see how to access those and ask any questions that you may have. So I'm Laurie Call, and I'm joined by Samantha Lasky, and we have several presenters today from IDPH. Amanda Fogelman, Stacy Hoferka Jensen, Antu Runas, Samantha Saini, John Tharp, and Stephen Roy. So we're thankful for their participation today and presentations, and hope that you enjoy this update. We're going to start off with a quick Zoom poll introduction. So Samantha's posting that now. Which of the following data have you accessed through IDPH in the past year? Select all that apply. Have you tapped into any syndromic surveillance, hospital discharge, behavioral risk factor surveillance survey, vital statistics, the cancer registry, anything in the new iQuery, or none of these? And there are no right or wrong answers. This is just an anonymous poll to capture the type of data that folks have been accessing. Samantha, how many have answered? We got about 64%. Anybody else want to answer? All right, probably good with the numbers based on the number of presenters we have. So it looks like iQuery is the highest. A lot of folks have been checking out iQuery. Vital statistics, BRFSS, great. Syndromic surveillance, okay. Cancer registry. So a lot, at least some people have checked into everything, and then there's 16% that haven't had a chance to access anything. So hopefully those numbers will increase after today's training. So thank you very much for that. We're going to move on to the next slide here. And as I said, today's training is going to be just introducing those data sets. So you'll see those all listed here. And we're going to start off with Amanda Fogelman, who's going to talk about just accessing IDPH data in general. And we have that time at the end for Q&A. So we'll look at the objectives for today on the next slide. You should be, as a result of this training, able to describe how to access IDPH syndromic surveillance, hospital discharge data, BRFSS, vital statistics, and cancer registry data after this session. And also, we're going to introduce the Healthy Illinois survey, talk about when data will be available and what type of data will be available. So you'll be able to answer that question. And then finally, you'll know who to contact if you have any questions at all about the Master Data Use Agreement or IDPH data sets. So those are the things we hope to accomplish. We have the same group agreements that we've had, and we will definitely answer any questions that you have either today, or we'll follow up with an email when we send out the slides and the recorded session to anyone who registered for it. And we'll just move on to the next slide. And here I'm going to gladly turn it over to Amanda Fogelman, the Chief Division for the Division of Health Data and Policy at IDPH. Amanda?
Thanks, Lori. Samantha, you can go ahead and go to the next slide, please. So as mentioned earlier, I'm going to talk a little bit about the Master Data Use Agreement, the iQuery, and how to access data at IDPH. So just a quick overview of the Master Data Use Agreement. If you are a public health administrator, you're probably a little more familiar with this as the actual document went out to them. So this was put into law through the Access to Public Health Data Act last year. to be used by local health departments to access IDPH data for prevention and control within their jurisdictions. So it is required to receive non-publicly available data from IDPH. That includes iQuery, Essence, BioSense, syndromic hospital discharge, and all other data sets. The master DUA is valid for a year. In the future, it'll be longer, but we wanted to make sure that it was a good fit for both the IDPH and the local health departments. So it covers the entire agency. So once the administrator or equivalent signs it, the actual master data use agreement covers the entire agency. And then if you need to request data, there is an additional document that you'll have to sign. So that's an Appendix B. If you have any questions at all about that master data use agreement, such as whether or not your agency has signed one or other questions about it, you can email me, and my email address is on there. If you have any questions about the actual document where we might have to discuss it with others, then that might take a little longer to respond. But if you have just a quick question, I'm usually pretty good at responding quickly. Next, please. So a quick update on kind of the process. So the master DUA document was finalized and distributed to the public health administrators on September 3rd. We do have dataset specific addendums. Those are in process. Those addendums really just talk about nuances of the data, any special requirements of those data sets, things like that, to make sure that people are using the data appropriately. For data requests, which I'll talk about a little bit more in the next couple slides, but for now, you can use the document with the guidance that IPHI will send out with these slides. In the near future, we'll have some sort of fillable form. We're still working out the details on that. And then in the further future, we'll have an agency-wide system. So that'll be on the internet. You can select your local health department from a drop-down list and be able to request data that way. Right now, we will maintain current methods for giving you data. That is very dependent on the data set and the data stewards, or you can use iQuery if you just need some aggregate data to fill out your IPLAN or a grant application. In the future, you'll be able to use iQuery, or they're developing a data repository called Snowflake that will allow access to our data. Next slide, please. So the PDF document that Samantha kindly put in the chat has, there's a little snip of it on there. It has the data set name, the responsible person, and their email address. If they have publicly available data, that's linked in there so you can access that quickly. And then how to request the data for non-research purposes. And the reason that that is asterisk is because if you need data for research purposes, there's a completely different process that you have to go through using our IRB system called Mentor, which I'm not really going to touch on much today. Next, please. So just a quick reminder, I know that some of you were able to attend the TA session where we talked about iQuery, so I'm not going to linger on it too long, but I do want just a reminder that it is a data repository for public health data. It has information from several of the data sets that IDPH houses, and some of the people who are data stewards of those data sets will be talking today. So the goal of that is to support IPLAN process. It's part of our data modernization efforts to give access to the data, or access to local health departments more easily. It's been moved to a Tableau-based system, so it is much easier to navigate and looks a little nicer. I put some of the new features down there. When you get the slides, you'll be able to click on the iQuery and get linked directly to it. You must have a master DUA on file to get access to it, but you can request access by going to dph.iquery@illinois.gov. Next, please. So just kind of a looking ahead with data access. We do have some current master DUA questions that we are working through that's requiring discussions with senior leadership and legal and others to make sure that we can adequately address those. We're looking at a temporary standardized data request system that's kind of what I mentioned earlier as the fillable form. There will be a tier access level questionnaire that local health departments will fill out to determine the level of access that they may receive. That will be discussed in the, I'm trying to remember the right name of the group, I apologize. It's a group that has some representatives from local health departments. So we want to go over that document with those representatives of local health departments before it goes out. So we're still working on that distribution plan. Then the agency-wide data request system is in development. We're in discussions with our IT to get that done. So that will not only allow you to request data, but it will also house all the documents and allow for bidirectional communication. And then we're also working on training and other policies to make sure everyone's on the same page. Next, please. And I'm done. So if you have any questions, happy to answer them at the end. Thank you.
Thanks so much, Amanda. I'm going to turn it over to Stacy now, and we do have a couple questions. As they're coming in, we'll make sure they get asked at the end, but it's great for the presenters to see them now and prepare their answers. So Stacy, take it away.
Okay, great. Just check that you can hear me okay. Is that true?
Perfect. Sounds good.
All right, great. Go ahead, go to the next slide. Hi, everyone. I'm not sure if everyone on the call knows me or not, but I'm Stacy Hofferka. I've been at IDPH for about 12 years, and the majority of the time I've been there, I've worked on the implementation of our syndromic surveillance system at IDPH. So for those who don't know, this is just a very brief overview and to tell you what to look forward to in future TA calls. This is a real-time data system. It is connected to every acute care hospital in Illinois. It collects information on emergency department visits and all inpatient visits. And we are starting to look into getting urgent care data as well. Data flows in every 15 minutes, and key pieces of information are going to be what hospital they're at, what time and date they visited, the geographic location down to the zip code of where the patient resides, obvious demographics, and then the key things in this system are going to be text on the chief complaint. What are they presenting with? What does the patient describe as their symptoms, as well as diagnosis codes, varying anywhere from like 1 or 2 diagnosis codes to some systems send us like 100. From that information of chief complaint and diagnosis code, we categorize a large percentage of the visits into syndromes. I'm going to show you use cases in a minute, but the idea is that it flows to IDPH. We retain the data locally in-house, and we also share it with CDC. The applications that we use at CDC are called like the BioSense platform overall, and a specific place to interact with the data is called Essence. You're going to hear more about, in the coming year as well, more about the fact that IDPH is implementing a local Essence that matches what the CDC supports for us so that we can do more with the data. The goal I always have with everybody who's on these calls, just talking about syndromic for the first time, is that I want to have at least one user at every health department who has access to the system. If you go to the next slide, I think I'll try to show you what the system can provide information on. Various use cases. Historically, communicable disease. Influenza-like illness. It was used extensively during COVID to provide information on emergency department trends and inpatient admissions. RSV. We use it for some bidirectional information. We try to identify people who are admitted and then notify hospitals that people have extensively drug-resistant organisms. But a lot of other use cases aren't communicable disease. Overdose trends. If we can help, we will set local health departments up with alerts to tell them when there are clusters of overdoses in their community. You can drill down into individual records to see if there's any kind of commonality in overdoses. It's been used for things like during coagulopathy. Folks have been around a while now. They remember those outbreaks and EVALI. We use it for heat-related illness events, cold-related illness events. It's being used more frequently now for firearms events and tracking surges or trends in firearms incidents. It's used for events. Think the solar eclipse if you're downstate, or the RNC, which we collaborate with Wisconsin on, or the DNC. When there were wildfires in Canada, we looked at asthma rates. So anything somebody can go to the ED for can be captured in the system. Maybe not perfectly, and we need enough data to know that they're there for that reason, but it's not limited to sort of just reportable diseases or anything like that. Next slide. There's some key features that we hope that even the local health departments that don't have a lot of time to work with the data will embrace with Essence and that we can support. And I'm not going to talk about these all, so I'm going to flash through these slides right now. This is just for awareness. There are dashboard capabilities. If you'd like to go to the next slide. There are capabilities in the system to set trend thresholds. So let's say you're a small jurisdiction and you want to know anytime you've seen 3 or more overdoses in a day. System can tell you that and send you an email. So we can help with setting up alerts. You can do statistical alerts too. If you're high volume and you want something that's like 95% abnormal over baseline, those alerts exist in the system too. You can do them for overdoses, respiratory, GI, norovirus, mental health related issues. And these are the things that when you're low on time, those alerts that come to your email are probably a tool you want to use from this application. Next. You can also extract the data in like cross tabs. So whatever you're looking for, if you want to stratify it by different demographics, different geographic regions, different hospitals, really easy features like Table Builder can take a query that you've developed and break it down and export it. You can put it into your SAS, your R, your SPSS, whatever tool you like. You can also work with dashboards. And as long as IDPH is aware of how you're using the data, that's one of our conditions of like signing the DUA is that you tell us how you're using it. We can support you or we can just be informational. Go on to the next slide. Okay, so I'm not going to talk much more today. I wanted everyone to know that this system exists. It's one of the ones covered under the Master DUA. We want every local health department to at least have one user who has access to at least the aggregate level of the data. You can get down to visit level data details, but that's usually only if you have like the need to know that much information. The CDC system is the current one that we access, but we are putting local Essence in place. The local one is advantageous because of some things. One, we've been able to bring in poison control data as well. So in one system, you can see trends for emergency departments and poison control calls. It is still in test, but we expect by January of next year to put it in production. Data will be available for syndromic surveillance back to 2027, or 2027, that's interesting, 2017. Poison control data goes back to 2000. We'll have data security in place that goes a little bit beyond what we can do with the CDC system. IDPH specific regions, so the 6 regions that we call our communicable disease regions or IDPH regions are in there, EMS regions are in there. And we look to do some additional enhancements as well. And we'll work with our locals to find out what you need and what you want too. So look for that to be a transition. If you're new to Essence, you may just start using our local system in 2025. If you've been using CDC Essence for a while, I think we're going to start having you think more about what the local system can offer. Next slide. Data access, your portal registration authority person in your health department makes the first request for your account. This is the website. At the bottom left, you go to the main webpage for IDPH for syndromic surveillance. There's a link. Portal registration authority person fills out, says you are in their health department, you deserve and need to have access to this data. I set you up with an aggregate account. If you need data details, you have to provide justification, and it's a second level of access. You would request it yourself, and we can create access based on rules of hospital visits in your jurisdiction or people who reside in your jurisdiction. I'm not going to spend any more time on this right now, but just know that it's the Poor Registration Authority, and there are links if you need to know how to access the syndromic surveillance data. Let me know. If you've already signed the master DEA, we're good to go. There's a few other forms you have to sign, a little bit more information. I'll provide you with some training. This is what I just said, so we can go on. Key points. Data is identifiable. Everything that you see in the system, just consider it all identifiable because it's free text. So it's always going to be protected health information. You're going to use it only for routine public health surveillance, always going to maintain it on secure systems. And yeah, again, letting us know what you're doing with the data. Okay, now you can go to the next slide. I'm not going to get into this today. I don't think we have time. Suffice it to say, at the next TA session in March, I'll be available. I can always give a little bit more information, but try to get involved before March because our vendor is going to be able to do in the early part of 2025 for the local system at least 3 training sessions of 90 minutes each. If you have the time, you can participate and you'll learn a lot about how to do syndromic surveillance. If you're time limited, those will be recorded, and I'm always available for TA if you're looking for shorter experiences in learning syndromic surveillance. So I'm not going to get into any of the interpretation stuff right now, and I think that might be my last slide. Okay, that concludes.
Thank you so much. It looks like we're ready for Antu.
Okay, yes, thank you. All right, this is for the Illinois discharge, hospital discharge data. My name is Antu Ronas. I am with the Division of Patient Safety and Quality. Some of the larger local health department probably know me, but some of the smaller ones don't. So the discharge data, I'm going to go through that really basic. Thank you. Okay, so it's a really rich data set, and it is available to local health departments and the public as well. And it provides information about the utilization and cost of the healthcare services. It is administrative billing data. So regarding surveillance, it's not an optimal one to use. However, just because due to the billing biases and things like that. However, it's incredibly rich because it does have like ICD-9 and 10 diagnosis codes. It has procedural codes that you can tap into. And one of the key things, right, with this is that it has a very complete, I should say, quote unquote, demographic and patient identifier ID information. So the demographic right now, there's a lot of, there are some groups that we're going to pilot where we're trying to grab that demographic information and match it with other data sources like the NHSN data for to get a more complete, you know, to tap into the health equity aspect of data. It also has charges by revenue codes, which most of you guys probably won't use a lot, but it is a very important when for research and stuff like that. Next slide, please. Thank you. So the data uses. So what is it used for? So for local health departments and internally surveillance, when it's used for surveillance, let's take it as a more global stuff, and it's not because it's not real time like syndromic, what have you. The hospital discharge data does have a 6-month lag. However, it is incredibly great for trending purposes because, as you can see here, it started collecting data from 1990. Not that you want that data right now, but and then in 2009, ED and observational data was added, and then we have just kind of note these dates because then when you request the data, these are kind of pivotal in regards to the change points, like what use you should be asking for. So in 2012, we actually were able to access patient identifiers. And that's really good and helpful for, readmissions and things like that, as well as we could create a unique identifiers to go through like multiple years worth of data. In 2015, diagnosis could transition from ICD-9 to ICD-10. And if you're not familiar with that, we went basically from what, I think 14,000 diagnosis codes to about 77,000, much more granular data is now available through the discharge data. And down there is the link for our discharge data set. So if you click on that, you can jump around. Okay, next slide, please. Okay, so it is a mandated, facilities in Illinois is mandated to report to IDPH all of the data. So that includes the acute care hospital, specialty hospital, ASTCs, diagnostic centers, so imaging you're able to access, and especially the emergency departments. So how does that data get collected? It's collected by our vendor, CompData, and quarterly, and we receive the data quarterly. So for us, it comes in every quarter, and therefore, but because of the 6 months lag, just kind of note that whenever you do your request, okay? So it's divided into two data sets: inpatient, so it's hospitalization data, and outpatient visits. And you can see here, these are encounters. It is by visit. It is not by patient. We have that information, but these are line listings for encounters, okay? Visits. And it is 1.5 million for hospitalization per year and 10 million encounters per year. And so when you're asking for line listings, and I think this is the reason why a lot of the smaller local health departments do not tap into this data source, because it is huge. It is huge. It is a lot of information there, and the lag also accounts for that. But if you're going to do trending and that kind of, and where you're assessing burden over time, it is an incredible data set. Next slide, please. So right now, how we're accessing is case level data requires a DUA with us, or an IGA in this case. So when you contact me, I will send you an initial data request, and that's an elements list and a data request form. You complete that, you send it back to me, and then there we go. Some groups may think about research, and research is vetted through IRB. Just don't do research. It takes a long time. There's a really long lead time for that. And then Stacy, as well as Amanda, has touched on a lot of limitations of like what you can use the data for and things like that, or how is it publicly reported on dashboards and things like that. It is all contained in our data use agreement right now, such as you cannot publish by the hospitals. They have to agree with some of the data first before posting. For jurisdiction, I have to see about that, and then suppression. Suppression is a key thing. For us, discharge data, it is 10 or less. It has to be suppressed. Next, please. Okay, so at this time, there are 50 plus data elements that are available to local health departments. I do not recommend to request all of that, because there's a lot of the stuff that you really do not need. And so why ask for all of that data? So some of these are the general ones that are really important, and is kind of something that I would recommend. Like the patient, we have patient information, admissions, the diagnosis process, 25 spots for that. And so you can really capture the burden of your community and what have you, procedural codes as well. we have a length of stay, which is great for a hospitalization. That's a relevant one. 3 spots for payer information, facility information, and then these 3 groupings here. These are classifications. If you've not used them before, we do recommend this. These will get you closer to many things that you might need for your assessment. Next slide, please. Okay, so at this point, there are already data that is publicly available on the hospital report card and the community map, and some data dashboards like iQuery that Amanda has talked about as well. But for us, we support we do support these 2. The hospital report card is individual hospitals, and then the Illinois Public Health Community Map is community-based, so it is by county. And I'm going to swipe the sharing. That screen sharing. Do you want to continue? Can I jump over with that one?
Yep.
Or do I just click yes?
Yeah, you
Okay.
click share screen.
Okay. Thank you.
There you go.
And so if you guys are not like familiar with these 2 sites, I just jump in it. It's really a lot of data is in here that's available since this is started in 2012. So let's say for like Lake County, just jump in here. It gives you the facility profiles and things like that of your other facilities in your county. And if you click onto that, it will give you a lot more information, the profile of the facilities. Some of the things that is kind of neat is this. We have the community health needs assessment for each individual hospital that you might find of interest. And there are data. I'm gonna again. Whoops, I'm sorry. There we are. And if you're looking at measures and things like that, it's all downloadable. So just kind of go in here, play with it. A lot of some of the local health departments currently use this now for HAI and things like that, and love that they can access data that way, aggregate data. So community map is this one, and that's by county, and you can hover on that. And there are just a ton of measures here as well. Most of this data is coming from the discharge data. So if you're interested in like the county near you, how they are doing compared to you regarding like cardiovascular diseases, you just click on this. There is just a lot: injury, maternal, oral health, and what have you. There is also an total ED. So you kind of drill down, and then it just you hover, and then it just gives you a lot of information. Again, all of the data is also by race. It's aggregate data. It could be exported here as well. So okay. Laura, you could take it back now if I could stop sharing. So I just wanted to kind of give you that that kind of overall, so where to access some of the discharge data. Thank you.
Ew.
And, oh, that's my contact number if you have any questions.
Thank you, Antu. I know we're moving fast and we're still a little behind, but please do put your questions in the chat and we'll get those answered. And I'm going to turn it over to Sam now.
Hello, everybody. I'm Sam Sani, and I'm going to share with you data available from some population health surveys here at IDPH. Next slide. The state of Illinois is one of the few states that actually conducts a survey to gather data on health behaviors and conditions at a county level. Historically, we've had the Illinois County Behavioral Risk Factor Survey. That's the ICBRFSS or BRFS. We also refer to this as the county BRFSS. So you'll probably hear me refer to that throughout the next 10 minutes. And this gathers information for individual counties. It mimics the CDC BRFSS survey that's done at a state level. The county survey is the primary source for Illinois counties for the county level data on health-related risk behaviors, chronic health conditions, and the use of preventative services for adults in our general population. Additionally, we now have the Healthy Illinois survey, and this is actually replacing the county BRFSS, and I will go over some specific details with that one in a couple of more slides. Next. The most recent data from the county BRFSS is round 7, which was collected from 2020 to 2023. Many of you may be familiar with how the county data is collected, but round 7 was a little bit of a change from historical, and I really wanted to point it out to this group. In previous data collection cycles, the data was collected on a group of counties, like until it was complete, and then they would move on to the next county. So like they do the lower half, they do like the lower geographies, the lower counties in the southern, and just work their way north. So any one county had their data collected within like a couple of months time frame. And round 7, we did not know COVID was coming, but round 7 was done in a way that all the counties were collected at the same time with the goal of like 100 per year over the 4-year period. This just was like a change that was made to make our data more comparable. And when the pandemic happened, it kind of worked in our favor because that meant all of the counties experienced the pandemic influences on their data collection equally. So all counties that collected data reflects all 4 years and are equally affected by the pandemic. So the data is perfectly comparable. The round 7 data analysis is complete and it's being prepped to publish to the website. And we expect to have that done by the end of the year. However, we already have this ready. So if you email us for your county report, we can send it to you at any time via email. Our email address on here is the dph.brfss@illinois.gov, and you can email us to get your data before publishing. Next. This is the data that was included in the round 7. This is the more routine health survey data. It should look very familiar. The healthcare access, chronic diseases, substance use. Of note that is new, it was not included in like previous data collection cycles, is the e-cigarette use and the marijuana use. Each of these sections, while like this is an overview of what was on the health survey, there's too many health measures to list individually. But for healthcare access, for example, that includes the percentage of people that have healthcare coverage, the type of coverage, barriers to care, whether or not they have a healthcare provider, when was their last checkup, how long ago, and a health literacy question. And there's actually a few other questions sprinkled in there that I didn't include. So while there's 24 categories listed on this slide, each one could have anywhere from 2 or 3 up to 10 health measures that you could utilize for your IPLANs. Next slide. All of our data is published online. It is an older but very functional website. Please note on that left-hand side there that you can select the state or the county options. So I just wanted to point that out because to get the county level data, you have to click on the county link there. Also on the left side, next slide. Also on that left-hand side is the option to view the questionnaire, which is really important when you're for you to find what you're looking for. You have to go to the bottom of that drop-down menu to get the county surveys. It'll say round 1, 2, 3, 4, 5, 6, 7. So that's all of the county questionnaires. So they would be on the bottom of that link. Next slide, please. So this is just an example of the data that is accessible on our website. This is for someone who selected round 6 data, because that's the newest data that we have on there right now. We're working to get round 7 up by the end of the year. The topic is alcohol and the county is Adams. The only difference between what you're seeing here today and what we're going to do for round 7 is that for round 7, we're aiming to have you either pick a topic like alcohol and you get all of the counties' alcohol rates, or you pick a county like Adams and then you get all of Adams data. So you're going to get more of a summary list instead of clicking around so much. You'll get everything in one click. Next slide. In addition to our online reports, we also do put together like actual reports in a Word document, and we send those out to the administrators listed for each local health department. I realize that that doesn't always make it to the person who is doing an IPLAN or who would utilize the data. So hopefully you're the people on the call today and you know you can reach out to us. You can ask for this or to have the paper form, or you can just get it from the website. Next slide. Okay, so I'm going to talk about Healthy Illinois survey for the next couple of minutes, and I'll try to be brief, but if you do have questions about this, please pop them in and the chat and I'll answer them at the end. Next. So Healthy Illinois came from legislation, and this is the legislation right here. It's replacing the county surveys, and what it is doing is really getting at the ability to get to more local level geographies. So not just reaching out to the county level, but we want to be able to develop rates at the zip code level as well. We also broke out all of the Cook County geographies. So Chicago has all of their community areas and their health equity zones, and the rest of Cook County is broken out into the municipalities. The zip code level data will be done with modeling, but I'm not going to get into the weeds with that here. And then the other part of the legislation here is just shows all of the general healthcare topics that they want to include. And some of them were a little bit new, like community level engagement. But otherwise, most of this is very familiar and follows through with like what you would already seen on the county BRFSS survey. So this is more of a continuation. Next slide. The differences from Healthy Illinois and the county BRFSS are just a few. Aside from like some methodological changes, one of the things that we were really able to do is use, because it's going by address, we're really able to focus in on neighborhoods a little bit better. So we'll be able to do oversampling for minorities. This really benefits a lot of counties that have more diversity. But it also is going to reduce the time frame to collect data, and I'll talk about that in a minute. Some of the topic areas, this is the overview of what is currently on the Healthy Illinois survey. However, the blue ones are ones that have never been included at the local level before, so they weren't on the county BRFSS survey. So with the focus on being like health equity, the social determinants of health is included, and this is specific to like financial security, food security, housing security, and employment security. And the other ones on here, your neighborhood really looks at like your community area, how safe you feel in your neighborhood, how routine it is for you to encounter violence in your neighborhood, transportation access, park access, etc. And then by popular request, not only was it listed in legislation, but the adverse childhood experiences was included, as this was requested since I've been here a number of times. Next slide. I think this is my last one. For the Healthy Illinois data, the data collection is throughout the entire year, so all of 2024. We started in April of this year because this is our first year doing data collection. But in future years, it will be January through December. We anticipate getting the cleaned data at IDPH by July 1, so we're hoping to have it some point in June. And we are working to be quite prepared to turn reports and publishing data around by August of that year. I want to talk about like the number of years to data collection because this is one of the things that we really were intending and expected to improve upon. The county BRFSS survey has always taken 4 years on average. It's taken 5 years in some cycles to collect enough data at every level of geography at all of the county levels. There are some geographies that are really small, and while we intend on as many geographies as possible to be able to have their data annually, some smaller counties are going to have 2 years of data collection in order to be able to produce all health measures. So some measures will be able to be done annually. Other health measures will require 2 years to be able to measure at a county level. It's still a vast improvement over our 4 or 5 year data collection. And this not only is the small counties, but we're finding that it applies to some of the smaller Chicago area community areas and Cook municipalities as well. This is no like a Healthy Illinois survey isn't going to fix everything with data collection. Some of the extremely small geographies may require 3 years on the health measures. And these would be the geographies, you know, way less than 10,000 population. It's just an issue with sampling. And I think that is my last slide.
Thanks so much, Sam, and that's really exciting. We're going to move on to John with vital statistics. And folks, we only have 10 more minutes left, and that's probably 5 minutes for John and 5 minutes for Stephen. So if your questions come in, we're going to be answering them in writing, and I'll just send the email out immediately following. So John, I'll go ahead and turn it over to you.
Okay, yeah, and I can be very brief. I just have a few slides. Hi, everyone. My name is John Tharp. I work in vital statistics at IDPH, and we are housed in the Division of Health Data and Policy under Amanda. I just wanted to point out, I have 2 email addresses down here. One's my individual work email address, and then the other one, the DPH Vital Stats, is our Vital Stats program email, and you can contact me at either one of those for anything. Next slide. So vital statistics basically uses vital records data, which mainly consists of births and deaths. But vital records also collects records on fetal deaths, abortions, marriages, and divorces. Vital records is a different division from ours, and they do all the data collection. They collect births, every birth that occurs in Illinois from hospitals, and it's an electronic data collection. And then they collect all deaths that occur in Illinois from funeral directors, and then coroners, physicians, and medical examiners contribute the cause of death part of that death certificate to that record. So for vital statistics, we work more on the aggregate side. So vital records collects it all, cleans it, maintains it, stores it, and then once we close out a year, that raw data is given to us, and then we are responsible for producing the aggregate statistics that we publish that go into, you know, iQuery, that go into our vital statistics tables that we have available on our website. And I have the website listed there. If you've never visited that before, I urge you to go there. We have a lot of published static tables in there with really good, you know, data by county. And in recent years, we've even added the sub-county health department in there. So like Evanston, Oak Park, etc. We have lines in those county tables for those health departments. Um, Part of what we do in here in vital statistics beyond just produce those aggregate statistics, we do a lot of special data requests from other programs in the department, and then a lot of folks from outside the agency um, work on a lot of special projects. We fulfill media requests and we work on FOIAs that we get through our legal department. So beyond like what you can get out of iQuery and what you can get off of our out of our website tables and or what you could get from like if you sent us a special request, you can go on to the next slide. Um, we have our vital records division has had in place for many years a process for local health departments to get access to those line level birth and death data. So if you have if you have the staffing and the resources to do your own analysis on record level data, that is available. And I know there's quite a few larger health departments that have been doing that for quite a few years, but I don't know how well known that is. So I just wanted to mention it here. Um, and if you do have interest in that, if you're not already doing that, I would urge you to email Vital Records at the DPH Vitals, and they can assist you with getting your files. And what they'll do is every time we close out a year, they will post those files. And I apologize, I'm not sure exactly what that consists of, but basically you would get access to folders and you could then export your own data for your own analysis. So I would urge you to do that if you have the capabilities to do that. And I think I'll stop there.
Great, thank you so much. And finally, Illinois State Cancer Registry, Stephen?
Yes, let me get there. Okay. Hopefully everyone can see that. So I just wanted to go through where to access our data and how to go about using it. It's pretty simple. This is our IDPH website. If you go to data and statistics and go to epidemiology, you will see us here on the side, Illinois State Cancer Registry, and this is our homepage. And if you scroll down a little bit, this is where our web query data is at. I'll access that in a minute. I want to scroll down a little further to show you that we have other resources as well. So we have here Illinois State Cancer Public Data Use Set. This is more for like researchers and those who are familiar with SAS and coding. Those are readily downloadable files, but if you're not familiar with those things, then the web query is going to be more pertinent to you. You also have these annual reports that we upload annually, and they should be there before the end of June each year. And basically, we're only up to reporting year of 2021, but we report incidence based on state incidence for cancers and mortality rates for the state, and we also do it by county. And we only go by 5-year aggregate data simply because we cannot identify subjects. And if we have a certain threshold that we have to meet, if we can't meet that, then we can't post the data. So you'll find in there that some data is actually missing. And the reason for that is because we want to keep that data confidential. So if you don't have the data that you're looking for in the web query, then you can find it maybe in those annual reports. So going to the web query, both of these links here will take you to the same spot. And basically, you can see immediately that we have males and females. So we segregate by sex or stratify by sex. And basically we're here in incidence. So you can select the data. If you want aggregate data, since we began in 1986, you can certainly click on that, and you can say if you're interested in all sites and all races, and you go to data, we will find that data for you. And if you want to download this data, you go to actions and you can download it in a PDF, Word, or Excel format. But going back to incidents, you can also look at data by ethnicity. So you can come over here. So if you're interested in, say, just a couple of years, you can select those years and a couple of sites. And for any race, it will only demonstrate for those years. It won't combine those years. So if you're looking for a combination of years and data for years, you can potentially go to the annual reports. But you can also combine data looking at it by county. And you'll see here that you can get combined 5-year data. So we can go to the state. And if you're interested in all races and all cancers, then you can get that data as well. We also do it by zip code. We also do it by stage. Stage is interesting. You're not going to have all the cancers listed, only specific ones. Again, confidentiality reasons. Going over here, 2005-year data. We can go to Illinois. You can go to breast, and you'll see that we have, according to localized, which is like the most earliest, regional and distant are more later stages. So if you combine those two, you get later stage cancers. In situ, we don't always look at. We're more interested in malignant type cancers, and in situs are more precancerous. So we do it for breast cancer, but you'll come over here and you do it for cervix. We don't collect it for cervix. So you'll see a 0 there. It doesn't mean that's the actual number. It just means we just don't collect that. So you just kind of ignore that. But beyond that, that's how you use that. If you're interested in mortality, well, for instance, we also do Chicago and suburban Cook by race ethnicity, and we also do mortality rates. And you can go and look at that by race and ethnicity. So that's it.
Thank you so much, Steve. And we are just wrapping up, and Samantha is going to be putting go ahead back to that Zoom if you don't mind. Samantha's putting a link in the chat, and we wanted to do just a really quick Zoom poll to close this out. If you needed to access any of the data sets that we talked about today, how confident are you that you could find where and how to access them based on today's session, with a 1 being not at all and a 4 being very confident? So not at all, somewhat confident, confident, or very confident. And if you wouldn't mind answering that poll and the short evaluation in the chat. We have compiled the questions that have come in already, and we put those in a document and are typing up the answers. We'll send them out as soon as possible. And if you have any other questions, don't hesitate to put them in the chat or to send an email to Samantha or myself, and we'll get those answered for you. And we thank you for going over a couple extra minutes here today. That was really, really helpful. So appreciate your time and staying on. Thank you so much. We're working on the 2025 IPLAN training series, and appreciate all of your input, and wish you all happy last month of the year. So thank you, everyone. And thank you very much to all of our presenters today for pulling together all that information and sharing it with you. You will receive the slides. You'll receive a recorded session. So hopefully you can use that as a resource to pull up. It sounds like most people are between somewhat and confident. And we've got a few folks who are very confident. And happy to say that no one has reported not at all confident. So at least you know where to go, and we'll make sure to continue this conversation with you and helping to provide access. Don't hesitate to reach out to any of the presenters, and when we follow up with the information, we'll include their contact information. Thanks, everyone.